Amazing, incredible. Good evening, everyone. Good evening. It's a pleasure to welcome all of you to tonight's TAMS Talks. Yeah, I'm really excited for tonight. I'm really excited for the topic we're going to cover today. It's a really pertinent one, it's a really important one. And yeah, so without any further ado, I'm just going to jump into the introductions. My name is Caleb. I'm currently an F1 in Manchester. Recently graduated from Exeter Medical School. Shout out, I've got the jumper right here. And as well as doing that, I'm also the co-director for TAMS Network. And so what does that mean? What's TAMS Network? So TAMS stands for the Aspiring Medic Support. And we exist for one thing and for one thing only, and that is to support aspiring medics from socio-economically disadvantaged backgrounds. And that could mean supporting an A-level student that's trying to get into medicine, but it could also mean supporting a final year medical student that's trying to graduate and to become a junior doctor. And that's what we're doing here tonight. So tonight is part of a series called Journey to FY1 that we within the TAMS team have developed because we feel that in final year, there's a lot of things that are pertinent and specific to final year itself that are different from the rest of medical school. You know, things like the PSA, things like the SJT, things like oral applications. So we wanted to bring some clarity and make sense of all of that flurry of new information that kind of comes onto your final year. So that's why this exists. That's why we're here tonight. And we have an excellent speaker. We're going to have another excellent speaker next week and another few after that. So throughout the month of November, you know, there's going to be 3 sessions. So we're excited for you to join us tonight, and we're excited for you to see you on the following evenings as we go on through the series. Right, so without any further ado, I'm going to invite Hannah, who is going to be leading the talk this evening. So as I mentioned, I just recently graduated from Exeter, and so did Hannah, and that's how I know her. So she's an incredible, the perfect person to lead this talk. So I hope you have your pens ready. I hope you have your listening ears open. And I'm just going to invite Hannah to, well, first of all, to introduce herself just a little bit. Hi, Hannah.
Awesome. Thank you, Caleb. Caleb and I have been friends since year 1, PBL together, first ever PBL group.
Shout out PBL.
It's possible. So my name's Hannah, I'm an F1 and I've stayed in Exeter to work. I'm currently in the emergency department and it's going okay. I'm still alive. I'm originally from Cardiff, but spent my years in Exeter. So tonight we're going to have a chat about the PSA. I'm guessing a lot of you guys are final year medical students, so congrats on surviving it this far. You're nearly there and there's just a few more hoops to jump through until you can be fully fledged doctors. Are we all right to start, Caleb? Am I okay to?
Absolutely, take it away.
Awesome. So tonight, guys, I'm basically just going to be giving you an overview of the PSA. I've decided not to go too heavy on any mock questions, because I think those are things that you can do in your own time and at your own pace. And we're still a way away from the PSA. It's normally done, I think, in term 2 or 3. God, I only did it recently, but it seems like ages ago. I can't remember the exact timing. So I thought today would be a good chance to provide an overview, dispel a few myths about the PSA. It's really not that hard. And if you just do a little bit of prep, you can pass it easily. So we'll be answering some questions at the end, but without further ado, let's begin. So I'm not sure how much you guys know about the PSA so far, so we're going to go really back to basics. What is the point of the PSA? Well, the point of the PSA is literally just to ensure that you are safe F1 level prescribers. They're not expecting you to prescribe chemotherapy or any weird drugs. They're expecting you to be able to prescribe and recognize errors in things that you'll come across in F1s when you're clerking in patients to AMU, when you're seeing them on the surgical take. You should be able to prescribe new medications for people to treat their new illnesses or new pain, and you should be able to recognize which drugs you should be stopping or changing in the context of a patient's unwellness. So if you're on a ward round and you spot that they are being treated for an AKI and they're taking a drug that could make that worse, you should be able to spot those simple errors. So the point is to make you safe. It's nothing that's designed to panic you. There's nothing there to catch you out. All the information is in the BNF, and you will be ready to take the PSA by that time in 5th year. The best prep for it is showing up for placement every day, seeing patients, going through their drug lists, and building on the knowledge that you had from 3rd and 4th year, and actually thinking about doses this time and thinking, okay, so what dose of bisoprolol do patients usually go on? And the more you get familiar with those kind of not precise numbers, but just kind of your ballpark figures, the more confident you're going to feel with whizzing through those questions at more of a timed pace. It's also important to know that you don't have to pass the PSA in final year. You can graduate without having passed the PSA. It's not the end of the world, but it is expected that you'll pass it by the end of F1, which I'm sure all of you will do. So please don't panic. I think it's something that stresses a lot of people out, but honestly, it's fine. And I didn't start revising for it until quite close to it, because just going to placement is revising for the PSA. Okay, so what does the exam actually look like? So it's quite a long exam, it's 2 hours, but it is quite time pressured because you've got lots of things to work through in that time. So there's 8 sections and 60 questions overall, and some will take you more time than others. So there's 200 marks up for grabs, and there's no pass mark. So it changes every year, and it's all based on stats and stuff like that. So don't worry too much about a pass mark. You just need to do as well as you can, and that's all you can do, isn't it? So the 8 sections all cover different topics. So they cover medicine, surgery, elder care, pediatrics, psychiatry, obs and gynae, and GP. So each of the questions that comes up on the PSA will be covering a certain specialty. So that can kind of guide your revision a bit. So the first section is the biggest section. This is where most of the marks are. This is the prescribing section. This is actually where you have to write appropriate treatments for a patient and choose the appropriate dose and everything like that. Then you have the prescription review section, and this sort of marks the beginning of the MCQ section. So most of the question bulk in the PSA is multiple choice. So in the prescription review section, you're given a little scenario and some drugs that a patient is taking, and they'll be given in a list, and you often have to pick which one of these drugs might be most likely contributing to the patient's hyperkalemia or renal failure or upper GI bleed. Which drug should you stop here? And you just have to choose them from the multiple choice list. Similarly, the planning management section is basically choosing from a list of management options what would be the most appropriate for your patient. So again, it's multiple choice, the answer is in front of you. And then the next section is providing information. So this again is multiple choice, and you have to choose some information that you might communicate to a patient about a treatment, such as what side effects they could expect, how they need to book in for any monitoring, stuff like that. And again, it's multiple choice, so it's about choosing information to communicate to a patient. Then you come on to the calculation skills part. Now this bit is easy marks if you've done your basic arithmetic practice, which is very easy to prep for, and there's lots of places online where you can just go through reams of questions, so it almost becomes automatic. So this isn't really something to worry about. If you can do basic dividing, multiplying, you'll be absolutely fine with the calculation skills section. It's easy marks. You just have to take your time, make sure everything's in the correct units. Then you come on to adverse drug reactions, which is either choosing a management or recognizing a drug that may be responsible for a certain reaction. There's pretty much always one about anaphylaxis in here. And again, this is multiple choice. Then you come on to drug monitoring, which again is a multiple choice section. And then there's a data interpretation section, which you may be given some blood tests on a patient, and you might have to choose an appropriate management based on those blood tests. So it's interpreting a bit of data and then choosing an action based on that data. So that's an overview of what you can expect from the PSA. So it's 2 hours, lots of different topics, but it is very manageable. So let's break it down and I'll give you some top tips. So I think it's worth speaking about the prescribing section. Let me just make sure I can see your chat at the same time in case any of you guys want to ask anything. More chat. Okay. Just checking that I can see it there. So if you have any questions, you can pop them in the chat as we go along, or I'll come to them at the end. So the prescribing section, there's 8 questions, so you've got to prescribe 8 drugs and you get 10 marks for each of these. This is really the bulk of your marks. This is 80 marks out of 200. But not to panic, if you don't choose the right drug, you can still pick up marks along the way. So you get 5 marks for the correct drug choice. Now, there might not always be one single drug. There might be a few drugs that are right, or a few different types of fluid that are right in this scenario. So let's say, for example, if you're treating a PE or a DVT, of course, the exact drug preparation that you'll be giving might differ depending on what trust you come from, but that's okay. They recognise this in the PSA, so you just have to choose an appropriate treatment. Similarly, if it's something like a chest infection and you're choosing antibiotics, there could be more than one right answer. Fluids, maintenance fluids, you might choose something different. There's not always one right answer. So you get 5 marks for the correct drug choice, and then an extra 5 marks are up for grabs for choosing the correct dose, route, and frequency. So unfortunately, you don't get points for writing the date and signing your name, which of course are points in terms of a legal prescription, because it's all sort of a pre-populated form, which I'll show you on the next slide. So this is what the prescribing questions look like. This is one that I've just pulled from the PSA website. Unfortunately, given that I've graduated now, they've deactivated my PSA account, which is very annoying because I couldn't get all the mock questions, and there's only 5 questions on the publicly available website. So definitely make sure as soon as your medical school sends you the login details to the PSA portal, have a look early. There's often some really useful resources on there, including mock questions. And it's best that you take the mock questions from the PSA people. You can go on PassMed and pay for all of them, but I actually don't think it's worth it. For the PSA, and I think for the SJT as well, you're much better off using the practice questions that the organisation themselves have made, because they're most likely to reflect the future exams they're going to set. So this is the one that can be seen on the PSA website. So it's clearly someone with a DVT following a long haul flight, and you're asked to prescribe something to treat her DVT. Now, you may be able to think of a treatment off the top of your head, which is great. If not, you can use a treatment summary on the BNF in the exam to find a treatment. But let's say we want to treat her with rivaroxaban. It's good if you know some treatments for some common conditions off the top of your head. You don't have to know the dose, but as long as you can type that drug into the BNF to find out the correct dose and frequency and route for the indication, it'll save you a lot of time. So I think that's my top tip for this prescribing section, is work your way through, you know, the back pages of the Oxford Handbook of Clinical Medicine, that yellow small book that would fit in your pocket that they do at most medical school libraries. It's everywhere. Make sure you know the basic treatments for all of the emergency presentations in the back of the book. And that way you can just quickly look up the drug in the BNF for this section, and you're on to a winner. So you prescribe something, but you must always ensure that you check for any interactants or contraindications. So they give you this little summary of the patient here, and sometimes they give you waffly information that you don't need to read. But if they're telling you a renal function or something about past medical history, make sure you bear it in mind and you're not prescribing something that's contraindicated in renal failure and say this patient's got renal failure. So always check the prescription that you've done and make sure that it's appropriate for the patient. Often, if they're giving you some information in the scenario, it's for a reason. So make sure you read it all. All right, so that's the prescribing section. Let's talk a bit more about what topics could come up. So I've taken all of this information from the PSA website. They've got a blueprint document, which has some really helpful information on. So the topics that could come up for your prescribing, of course, include your acute presentations. So MIs, PEs, DVTs, anything that's in those final red pages of that Oxford Handbook are worth knowing. You know, acute treatment of heart failure, an acute asthma attack. You need to know your basic treatments, and then you can just quickly look them up for dose and route and frequency and stuff. That way you won't miss a trick. Common infections. So think of all your body systems. So you need to know an antibiotic that can cover you from top to toe. So you need a good one for chest infections, urine infections, skin infections like cellulitis. They come up really often. So just making sure that you've got an oral and an IV one for each of those, depending on how unwell the patient might be in the scenario. Fluid maintenance also pretty much always comes up. So making sure that you know your principles of fluid maintenance and also resuscitation and recognizing the difference. So obviously fluid resuscitation, most people, it's 500 mils of normal saline over 15 minutes. Would be different if they had cardiac failure. And knowing about maintenance fluids as well, and things like adding potassium to fluids is worth having a read about. And pain relief is another common thing that comes up. So thinking about principles of managing acute pain. So if someone comes in and they've been involved in an RTC and their legs hanging off and will need relocating, you're going to be reaching for things like your morphine. And then also thinking about your like longer term pain relief and stepping up that WHO analgesic ladder. So these are all topics that the PSA people have said these are going to come up in your prescribing. So just making sure that you're covering all of these areas in your prep. And this is what they say. Typical scenarios involve the treatment of acute conditions, e.g. asthma attack, heart failure, chronic conditions, and important symptoms such as pain. So they're telling you what's going to come up in the PSA. So let that be the scaffold for your preparation. So moving on to the other multiple choice sections now, which forms kind of the bulk of the rest of the marks bar the calculation skills. This is what your typical question would look like. This is what the interface looks like. It'll fiddle around when you obviously log into the PSA portal. But these buttons up here, I think you can probably see my mouse on the screen now. The buttons up here, this little book here will take you to the BNF in the exam, and the calculator will take you to the on-screen calculator, which is the only one we're allowed to use. I've just got a question in the chat. Are we only allowed to use the web BNF, not the app? I find the web BNF harder to navigate, especially the treatment summary section. So yes, you are only allowed to use the web BNF, but don't panic. The web BNF is actually great because you can use Control F to find your relevant information because it comes up as a big web page. So you can search for interactants and any word that you're looking for really quickly. You get two options for the BNF in the PSA. You can either use the one that comes up from NICE, which is my preferred one. That's like the format you're probably used to seeing it on. Or you can use one called the Medicines Complete BNF, which you can probably access through your medical school single sign-on. Some people like using the Medicines Complete one because it has an interactions checker. So when you're actually in the exam, you have this exam page that you see here in a web page window. And then when you click on the BNF, it opens the BNF in another window, which you can like Control F and search and stuff. So it's actually really user-friendly and really quick. So I would recommend when you're doing a PSA prep that you practice it on your computer or on a computer with a mouse, and you practice using two web pages. So the BNF open on one and then the PSA open on the other. So you're practicing using it in that format because you won't be allowed your phones during the exam. So I hope that answers your question, Sarah. So this is what the multiple choice sections look like. So you can see here, you've got a little case about a man with hematemesis, and you can see his regular medications are given in this big list. So we've been asked to select the two prescriptions that are most likely to be the cause of his hematemesis. Do you guys want to have a go in the chat at answering question A? So two prescriptions that are most likely to be the cause of his hematemesis. I told you I wouldn't ask you any questions, but I kind of can't resist. Yeah, definitely. Ibuprofen would definitely be one of them. And what about another one? An aspirin, yeah. So ibuprofen obviously causes a bit of gastric irritation, particularly if it's been taking over a prolonged period of time and in an elderly person. And aspirin is an irreversible inhibitor of platelets. So yes, aspirin also would be contributing to hematemesis. SK, I think you DM'd me, so no one else could see your message, but you were right. Great. Another top tip about aspirin, if you guys didn't know, you probably know this already, but it takes 7 days for aspirin to wear off because it irreversibly binds to platelets. Sometimes that can come up in the PSA, so why not mention it now as I remember it. So question B then, select the two prescriptions that are most likely to be contributing to his impaired renal function. Any takers in the chat? Yeah, so I think it's definitely, oh, hey, Victor. It's definitely, ramipril would definitely be one, yeah, an ACE inhibitor. And yeah, metformin is contraindicated in AKI because you have an increased risk of lactic acidosis. I don't actually have the mark scheme here, but I think it's probably looking for ibuprofen and ramipril. But you're right, Victor, metformin should also be reduced or particularly stopped if they're in AKI. Can we use the same drugs for both questions? Yeah, sometimes there'll be some overlap between the questions. So I think the right answers in this case are ibuprofen and aspirin, and ramipril and ibuprofen, because they're the most likely drugs to be causing his renal failure. And we'll come on to that in a second. I've got a little cheat sheet about renal failure and AKI and drugs. Awesome. Also, it's kind of always ibuprofen. Ibuprofen's rubbish. So I just wanted to kind of like bring your attention to the different headings in the BNF and basically what the multiple choice questions are getting at. They're right, the answers are in the BNF for the PSA. You've just got to know exactly where to look, and you've got to know where to look quite quickly. You can, as I say, Control F, so search the web page, but it's really good if you can navigate the BNF quickly. So I just wanted to kind of highlight the links between the question types and the sections in the PSA and where you can find the information in the BNF if it wasn't already kind of obvious to you, because I don't feel like this is actually that well explained. So I've already gone through all the different question types, which you can see here on the right. So when we're thinking about the prescription review questions, which is like the one we've just seen, which drug might be causing X, Y, or Z. Good places to look are in the interactions and side effects section of the BNF. So, for example, it's really common that they ask you about electrolyte abnormalities and which drug might be causing hypo or hyperkalemia, natremia, da-da-da-da-da. That information will all be found in the side effects section of a drug. So it's good to look there. Interactions often come up on prescription review as well, so that's obviously a helpful section. Then when we're thinking about our kind of planning management, so which drug would we use in this patient, it's really important that you're checking the renal impairment and hepatic impairment sections, because often here they'll be asking you about renal failure and liver failure and giving you some blood tests and ensuring that you choose a treatment that's appropriate. So if you really want to check the deal in renal failure and liver failure quickly, go to those sections. Then the communicating information section, so thinking about what we're going to tell our patients to watch out for, what's the most important advice about a drug. Often there'll be stuff here about contraception and breastfeeding and the most important advice to give to a patient. So I've used methotrexate here to illustrate this point, because obviously contraceptive advice is really important to be giving to patients on methotrexate because it's quite teratogenic. So always making sure you're looking in those sections for a drug. And also if they've given you a drug and they're saying, oh, a patient's about to be started on sodium valproate, well, whichever drug you have, if there's a contraception section in the drug summary, chances are that's an important bit of advice to be giving to the female patient, because not all drugs actually have these sections. So if there's nothing to be said to the patient in terms of breastfeeding or contraception, there's not going to be a BNF heading there. So just so you know, these things are very useful to have at the back of your mind when you're thinking, God, where can I get this information from when you're under time pressure? And then finally, of course, there's a drug monitoring section. So the monitoring requirements for any drug, any blood tests a patient might need to have, any serial ECGs, things like that, all the details should be in monitoring requirements, if not in patient care and advice. Okay, so moving on to some more hacks then, and things to think about when you're doing particularly the MCQs, but also when you're writing the prescriptions in the prescribing section. You'll be able to get to the NICE BNF through the PSA portal, and they have some really useful treatment summaries on there. And I would recommend having a good read of them before and picking out the key points as part of your kind of PSA prep, so you know where to find the information when you're in a hurry. But also it's good revision for what drugs to use when and stuff. So there's a really good one about hypoglycemia. Hypoglycemia often comes up as a prescribing one because it's kind of like an emergency. It's obviously a very common thing to be called to as an F1 overnight. So there's a nice treatment summary about hypoglycemia and what to do if the patient is awake, if they're able to swallow, but also if you need to be giving more emergency treatment via other routes. There's a good one about oral anticoagulants. Often things will come up in the PSA about surgery and when to restart anticoagulation, but also if patients are actively bleeding, what reversal treatments to give them. That information can all be found on the oral anticoagulants page. Also stuff to do with INRs and what to do with patients' warfarin when the INRs are in certain ranges. There's also a really good treatment summary about contraceptives. And I think it's really important to ensure that you know the indications and contraindications for contraceptives. So knowing the UK MEC guidelines and when women can and can't have the combined oral contraceptive pill. Also knowing the drug types for terminations of pregnancy are important. That often comes up as well. And then there's a separate section on sex hormones, which is where you can find your HRT advice. And I wish I'd known this in my PSA because I definitely didn't answer the HRT one correctly. HRT is a bit complicated as well. It's worth having a good read about that before the PSA. And I don't think the sex hormones page comes up if you type in HRT onto the BNF. So it's just to know that page is there if you need it. And then there's also a very good one on venous thromboembolisms, should you need to look that up in the exam as well. There's many more. Go and have a little browse, but those are the ones that I would say are helpful. Another hack, this isn't a treatment summary, but this is under the medicines guidance section in the NICE BNF, and it's called Prescribing in Palliative Care. And it's so useful if you get any questions about opioid conversions. So often there'll be somebody who's on a lot of morphine because they've got cancer pain and they're having lots of breakthrough pain. So they're taking more of their morphine. So you need to prescribe them something on a syringe driver or something stronger, something more regular to get more on top of their pain. And if you scroll down on this treatment page, there's a really useful table that gives you the equivalent doses of different opioids. So you can always work your way back from the oral morphine dose here. So for example, if you've got someone who's taking a combined daily dose of 10 milligrams of morphine, if you're going to be converting them to an IM or subcut route, you'd approximately half the dose. And I'm sure you can appreciate the maths for all of the other numbers. So that's a really good thing to have a look at, and just kind of having an awareness of what to do in patients who are already on quite a few opioids. And that's where to go for information. So another important thing that I wanted to cover were drugs to watch and drugs to be aware of. When you're faced with a long list of drugs, you don't really have time, if you're not sure of the answer off the top of your head, you don't really have time to be looking up every drug in the BNF. You need to have kind of a good idea of what drugs may be causing what, first of all. So I think ones that are really good to cover are drugs that are likely to cause AKI, because these drugs likely wreak havoc in other forms in medically unwell patients anyway. So I don't know if you've heard of the acronym CANDA, CANDA. They each stand for a group of drugs that cause AKI. So I don't know if you guys would want to pop some drugs in the chat that you know cause AKI. Some of them may have already been mentioned this evening. Following that mnemonic. Diuretics, yeah, awesome. Any others beginning with A? ACE inhibitors, yes, Victor. I feel like I may have told you this before, Victor. Don't know if this is cheating. Victor was in my OSCE group. NSAIDs, yeah, awesome, that's the N. So ibuprofen, naproxen, diclofenac, all of those stuff. Okay, so we've got aminoglycosides, yep, and so we just need, I think we've got all of them, have we? No, C. Oh, you guys are never going to get C. I'll give you a clue. Yes, contrast. Yes, well done. Okie dokie. So contrast is C. A is aminoglycosides, things like gentamicin, and I think neomycin is an aminoglycoside as well, but you never really come across that very often. NSAIDs, diuretics, particularly furosemide, and ACE inhibitors and angiotensin receptor blockers. So they're drugs to watch. When they come up in one of those listy things, like if it's anything to do with electrolytes or renal impairment, like go to them first. Also, as we've already mentioned today, be aware of metformin, especially in someone with AKI, that can cause lactic acidosis. Other oral hypoglycemics are always kind of naughty drugs to watch out for. So you're like sulfonylureas, pioglitazone, things like that. And always watch out for statins as well, because in AKI they can accumulate and lead to rhabdomyolysis as well. So it's just having an awareness of the naughty drugs that often are the ones wreaking havoc in the body. Other drugs that are ones to watch out for in the PSA are ones that are involved in the CYP450 pathway. So as I'm sure you guys know, CYP450 are liver enzymes that metabolize a variety of different drugs. There's various different types of CYP450, and they break the drugs down so they can be excreted. Various common drugs are metabolized in this way, which I've listed there. Warfarin's a biggie. There's going to be someone bleeding on warfarin in the PSA. You just know it. But don't worry, now you know the oral anticoagulant treatment summary page exists. You will be fine. So There are certain drugs that induce this pathway, so they make the enzyme work better and will break the drug down quicker. So if somebody is taking one of these inducers, so say they are taking phenytoin and they also happen to be taking warfarin, it's going to reduce the amount of effective warfarin they have in their system because it's being broken down quicker. Really important with the combined oral contraceptive as well, and steroids. And then inhibitors do the reverse, so they will inhibit the breakdown of a drug, so it will accumulate and become more toxic. So somebody taking an inhibitor and warfarin will be more bleedy. So it's just to be aware of these drugs listed here, and that often, I wouldn't go into committing them to memory, but just being aware of the sort of drugs to be looking out for. And you can obviously look them up with these acronyms, which I didn't make up, but there's crap GPs and sickfaces.com are ways of remembering them. So they're just drugs to watch out for if they're listed on a prescription. And also, just a further point, it's just always the antipsychotic on the PSA. They're dirty and they have all sorts of side effects. Another thing that often comes up in the PSA is if somebody's taken a load of antipsychotic and they have muscle spasms, they may be experiencing acute dystonia or tardive dyskinesia, and you need to be giving them the antidote, which is, does anyone know the antidote to acute dystonia as a result of having too many antipsychotics? Procyclidine. Very well done, Sarah. See, you guys are going to smash the PSA. So my general tips are: use Control F. You can search for information really quickly in that way, so practice doing it. If you want to get nerdy about interactions, I just manually searched for them and sort of had a vague idea of which drugs may be interacting already using those previous strategies that I've already talked about. So thinking about CANDA and thinking about the CYP450 pathways. They're like the common ways that they'll be asking the interaction questions. But if you really want to, Medicines Complete has an interactions checker. And my other tip would be, in the interest of time in the PSA, read the question first before you read the whole scenario, because actually the scenario might be kind of irrelevant to quite a straightforward question. Obviously, always read the scenario, but sometimes you can get away with not. I can't think of an example off the top of my head, but sometimes the scenario is like not that relevant and it might just be like, what's the first line treatment for blah. Okay, so how would I prepare? Use the PSA website, log on to it early, do the mocks that they provide you with. They're the best ones. I didn't do the mocks, but I would recommend that you do because I think they're probably quite helpful. They have a blueprint document on there, which is where I got all the information from, well, a lot of the information from about the exam today, which covers the topics that they may suggest and various scenarios. Practice your drug dose arithmetic calculations. There's lots of nursing websites that are all to do with working out volumes and dilutions and converting between the units. Those are really important to do under pressure, making sure that you're not getting your units wrong and putting everything all in one unit at the very beginning so as not to get caught out, and practice doing those under timed conditions, of course. Practice everything under timed conditions if you can, searching things up in the BNF. I would say, obviously, start off your revision slower at your own pace, but then ultimately the best thing that you can do is practice a whole paper under timed conditions. And familiarise yourself with the BNF. Those headings are there to give you clues. Recognise where the questions are trying to make you go to look for information. And this is just a little table that I stole from the blueprint document, which I just wanted to leave up here, which just gave you some example kind of scenarios that they might be asking about in the different question sections. So here you can see, if we go down to the data interpretation section, it might be that they give you some TFTs, some thyroid function tests, and a question might be, okay, so they've got these thyroid function tests, what should we do about their thyroxine? And there'll be sort of multiple choice questions as about that. So it's worth having a little look at this table, having a think about the scenarios that could result from them and how you might deal with them in different ways. And having a look at the drugs that they suggest on this table. So that can be seen in the blueprint document on the PSA website, which is under the FAQs section. And that pretty much ends it, guys. Thank you so much for coming. Feel free to drop me an email if you have any other questions, but I'm going to stop sharing my screen now.
Amazing. Wow. Wow. That was, whew. Wow.
We'll do it again, Caleb. Don't do the PSA.
I feel like if I could go back and like, know all of this stuff, that was so good. Thanks so much, Hannah. Yeah, where's the reactions? Let me do some claps there. There we go. I just wanted to give space for people to ask some questions. Yeah, so many thank yous on the chats as well. So thanks so much. That was excellent. And what I loved about it is that you didn't just go through a series of questions. You kind of gave us like tips and tricks and kind of like the hacks, and really loved that kind of understanding the principles that help you excel in the PSA, which I think were excellent. Fantastic. So someone's just asked, are there any websites that you particularly recommend to practice calculations?
Yeah, I can't remember the name of the websites exactly, but they were nursing ones, and they were all I think I just typed in like drug dose calculation questions on Google and chose one. I mean, it's basically just making sure that there's a variety of questions. You're going different ways about the equation. There's an equation, isn't there, Caleb, which is like what you want equals what you've got over da 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 da. Someone please help me out of my misery by writing it in the chat. But anyway, there's ways of doing these calculations. Nurses do them all the time. So there's plenty of free practice things online. I had PassMed, but I didn't use it. So I wouldn't say paying for any of these questions is worth it at all. Also, you can get some books sometimes from the library, and they might not be in the medicine section, but they'll be in the nursing section, because they're always drawing stuff up, diluting it, and that's what the questions are about.
Yeah.
Just making sure you go from like micrograms to milligrams to grams.
That's the one. Yeah, absolutely. I've seen nurses on the ward use it on some of these websites, and yeah, they're really good. I think what you said, like calculations are one of those things. Once you do a few, you kind of know the what tends to come up and the type of calculations that tend to come up. So that's what I thought.
Yeah.
So.
And you're like, I'm not going to fall for the units thing.
You're not catching me out again. No, not this time. But yeah, amazing. Okay, fantastic. Does anyone have any sort of other general questions regarding anything to do with final year at all, or maybe just F1, because we're both F1. So I wanted to give a couple of minutes to answer any questions that people have. So if there are any, just pop them below. But just before, I also want to ask Hannah, just because I think people will find this useful, is just obviously, you know, you've made that step from final year to being a doctor. Looking back, and you know, we've got fourth years here, we've got fifth years here, but like, what general advice would you give? You know, seeing you've done it for nearly 4 months now, coming to the end of the first rotation. I feel like I'm just describing my life to you. Coming to the end of your first rotation. So like, looking back on it, like, how have you felt it's gone, and what advice would you give to students?
So in final year, I would definitely say take everything one step at a time. I think right now it might feel like there's loads in front of you, and oh my God, how am I going to prepare for the PSA and the SJT and da 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 da. But they're all quite spaced out, and they don't require as much prep as you think, because everything's been leading up to this point, and you're very well prepared already. It's just literally learning how to sit that specific exam and how to press the buttons on their website. So take one day at a time would be my best advice for that. And yeah, in terms of like work, well, enjoy being a student and have a nice summer before it starts, because then you just end up in a rota, but at least you get paid. And it can be quite tiring. Have you found it quite tiring?
Yeah, I certainly. I think 12-hour shifts, like, you never have to do those as a student, and I think they can come as a shock. So yeah,
and you have to be there.
Yeah, you have to be in the afternoon. Very strange idea, but no, I echo what you just said about, I think, just taking it one step at a time. I think the PSA at the start, it feels like a daunting exam, but then you realize a lot of the, just general medical exams you've been doing throughout med school have prepped you a lot for the PSA in itself. You just start kind of channeling it in some sense and just kind of tweaking it and making it kind of specific for this exam, I think is what's needed.
Yeah,
so,
and every time you're on a ward round, thinking like, oh, why have they stopped that drug then? Or why have they started on a different one? And getting involved in making those decisions in 5th year, trying to write drug charts where you can, and get involved with writing notes and stuff, and you'll all just absorb it by osmosis.
Absolutely.
Enjoy being a student.
All just happens naturally. Thank you. Well, thank you so much, Hannah. If there are no more questions, I think we have a short video just to share with everyone, just a bit more about TAMS and just how you can get more involved with, TAMS and hear more about some of these amazing gems and knowledge that we've just shared tonight. So
my name's Kareem and I am a 4th year medical student at King's College London. I am also the co-director for the Aspiring Medics Support Network, also known as TAMS. And it's my absolute pleasure to announce the relaunch of the TAMS network. In case you haven't heard of us, TAMS is a registered community interest company dedicated to supporting aspiring medical students from socio-economically disadvantaged backgrounds within the UK. The TAMS network is a branch of TAMS which specifically focuses on the personal and professional development of medical students within our community. We know that medical school can be both an exciting and nerve-wracking time for many students, especially those from a socio-economically disadvantaged background, as they can find it challenging to adjust to the cultural and academic changes. Our work is just as important for the secondary school student who dreams of one day being a doctor as it is for the medical student who is mapping out their career choices. Because at the end of the day, we're all aspiring medics, we're just at different stages of our journey. We cultivate the personal and professional development of our members, specifically addressing the challenges that can come from a socio-economically disadvantaged background. We give people a place to learn, grow, and connect in ways that aren't currently supported by the medical curriculum. Our webinar series, TAMS Talks, is committed to meeting your learning needs. We address under-discussed topics at medical school, such as how to manage your money, choosing a specialty, and how to study for exams. Through our mentoring program, Mentored by TAMS, we provide impactful mentoring relationships that help our members grow into the best versions of themselves. We organise frequent socials for our members because we want to create a space for members to meet like-minded people and develop long-lasting relationships. To get involved, click the link in our bio to join our community. Once you do this, you'll receive exclusive access to all the incredible work the team is doing, which means you'll have the drop on the next TAMS Talks, mentoring developments, and opportunities to get involved with wider TAMS work. TAMS Network, a place to learn, grow, and connect.
amazing.
Hey everyone.
Amazing. Thank you, Kareem. So that's TAMS Network, guys, and we're going to be sharing the link in the chat for you to join and for you to just get involved with what we're doing. There's also a QR code there. So this QR code is for a feedback form. So as we know, Hannah's done such an incredible job this evening, and we would love for you to just drop some feedback for her, but also for TAMS in putting this on tonight. So there's a link in the chat. Just click on that link or scan the QR code. Yeah, that would be so appreciated. It only takes two minutes. There's only a few points to answer there. So we really appreciate that. And yeah, and also just to say, of course, we're having another session next week. We're covering all things SJT. So be there and make sure you invite somebody. You know, there's going to be hosting a giveaway, so if you invite somebody, you'll be able to enter yourself into a giveaway, so you get a £20 shopping voucher. Why not? Why wouldn't you want that? So next week we're doing all things SJT. In the week after that, we're having a panel with a group of F1s and F2s, and we're going to be talking all things about ranking jobs, about deaneries, selecting them, how do you approach it, and yeah, how do you kind of navigate that whole job ranking situation. So that's what we're going to be covering over the next few weeks. Please fill in the feedback form, and we have one final video to share, and we will call it an evening.